Thank you so much for joining us today. I am Ann Kelsey Lamb, the Director of Regional Asthma Management and Prevention, also known as RAMP. I'm excited today to have an inspiring discussion about sustainable financing for home-based asthma services. Asthma home visiting is an evidence-based intervention proven to reduce healthcare costs and improve asthma outcomes. Despite robust evidence of their impact, however, historically, programs have had to rely on unstable grant funding to provide these services. But in recent years, that pattern has begun to shift, and we have seen progress in communities and states across the country in building systems for sustainable asthma home visiting services. There are many different pathways for achieving success. As such, progress can look different from one place to the next. This webinar will feature success stories from across the country, highlighting state Medicaid policy advances, stories about local partnerships, and other innovations that create a groundswell for statewide change, all serving as models for others across the country. Next slide, please. These stories and more are featured in a tool that RAMP and our partners at the National Center for Healthy Housing co-developed called Sustainable Financing for Home-Based Asthma Services, Snapshots of Innovation and Progress Across the Country. There's a link in the chat. It is important to note that the kinds of success we'll hear about today can only be achieved through the collective efforts of a broad base of diverse partners over time. In many cases, the successes of today build on the efforts of other leaders from years, if not decades, prior. There have been numerous funders that have helped launch these efforts, a variety of technical assistance providers that have accelerated these efforts, and coalitions of partners that made them possible. Next slide, please. By the end of today's webinar, we hope that participants will understand what progress and pathways might look like, identify one or more pathways that may lead towards sustainable home-based asthma services in your community or state, and know how to access free technical assistance and tools to support efforts in your community or state. Next slide, please. We have an amazing team of panelists with us today. After I introduce them, each will spend about 5 minutes presenting on their success in working towards sustainable financing for asthma home visiting services. Then we'll move into a discussion where I will ask some questions of the panelists and I'll incorporate audience questions as well. So as questions come up for you while you're listening, please share them in the chat. Without further ado, I would like to introduce our panelists. Lindley Syag with the New York State Department of Health, Peggy Gaddy with the Missouri Department of Health and Senior Services, Natalie Tallis with Alexandria Health Department, Molly Zemke with the Wisconsin Department of Health Services, and Paula Holigan with the New Hampshire Department of Health and Human Services. Thank you all for joining us today, and I will first turn it over to Lindley to share about their progress in New York.
Thank you, Anne, and to the RAMP and NCHH teams for inviting New York to join this discussion. Good afternoon, everyone. In New York, we've been working to attain sustainable financing for home-based asthma services since the early to mid-2000s, which is described in New York's Snapshot. And as Anne noted, today's gains are really built upon past efforts and many champions prior, including Amanda Reddy, who published evaluation findings demonstrating an ROI for New York's still continuing Healthy Neighborhoods program. New York also supports a home-based asthma program delivered through a federally qualified health center in the Bronx, and is wrapping up implementation at the end of this month, New York's Healthy Homes Value-Based Payment Pilot, a joint effort with and supported by New York State Energy Research and Development Authority, or NYSERDA. So all of these programs, together with promising practices achieved under a former 1115 waiver, have really contributed to gaining needed traction for inclusion of home-based asthma services under the current 1115 Medicaid waiver amendment, New York Health Equity Reform, which is what I'll focus on today. Next slide, please. So New York's approach included establishment of regional coordinating entities referred to as social care networks, or SCNs. SCNs launched in 2025 are tasked with supporting community capacity to identify unmet social needs of Medicaid members and navigate members to the appropriate level of services to address health-related social needs, or HRSN. Tasked with building and managing a network of HRSN providers and partners, including CBOs, regional nonprofits, healthcare organizations, and health plans, and integrating healthcare and social care systems through a single regional technology platform positioned to facilitate sustainable reimbursement through Medicaid. New York's 9 social care networks, whose regional coverage is shown here, share the aim of improving health outcomes through the expansion of preventive care to achieve the intended subsequent reduction of avoidable hospitalizations, emergency department visits, and institutional care. Next slide, please. So this shows a high-level walkthrough of how a Medicaid member engages with an SCN to access available benefits. The first step is for a member to complete a screening tool and eligibility assessment that identifies household needs. Based on needs identified, a member is then either navigated to existing community supports, or for a member in an enhanced services population, for example, a child with asthma, referred to enhanced HRSN services covered under Medicaid and coordinated by the SCN. Enhanced services span 4 domains. You can see here: nutrition, housing, social care management, and transportation. And under the housing domain, asthma remediation services are included as a listed benefit, and members in an enhanced population who meet clinical criteria for uncontrolled asthma can receive medically necessary home-based asthma services. Next slide, please. So there are several categories of Healthy Homes interventions. The first, labeled 2.1, is home accessibility and safety modifications, which include, for example, accessibility ramps, handrails, grab bars, widening of doorways, pathways, etc. The next, 2.2, is home remediation for mold and pests, installation of ventilation improving systems, and equipment provision. And then third, 2.3, asthma remediation. So under 2.3, services include assessment of environmental asthma triggers and development of scope of work outlining remediation measures. And these may include ventilation system upgrades or repairs, carpet steam cleaning or removal, moisture control, air sealing, and provision of supportive products. And 2.3 additionally includes comprehensive asthma self-management education, which is typically provided by a CHW, and a member qualifying for 2.3 automatically qualifies for referral to 2.2 components and then can access the total member benefit cap of $18,000 for this work. Next slide, please. So in terms of factors for success, I think Anne's introduction alluded to several that were top of mind for sharing for today, including being prepared and flexible to make adjustments and really even change directions entirely. We certainly learned this through the Healthy Homes pilot, which traversed the years of COVID pandemic and required multiple resets and even redesign. Originally, we aimed to adopt an in lieu of services for Medicaid managed care plan integration of home-based asthma benefits, but as New York State Medicaid narrowed in on the SCN model, we really had to shift our focus to ensuring integration of asthma remediation services as an HRSN benefit. And so while this was a redirection, we were fortunately able to build on work we'd already put into previously developing the ILS. And next, while seemingly obvious, taking the time to find the right partners who are really willing to hold hands with you during what at times can feel like a free fall. And this is so critical because this work, as we know, happens often in baby steps, and finding partners committed to staying by your side isn't always easy. If you keep looking, you will find them, and partners may even fall off for a time. For example, we had a pilot CBO partner who just wasn't able to maintain organizational capacity to continue delivering pilot services a few years ago, but just recently actually rejoined these efforts and contracted with an SCN. So maintaining those partner connections and being open to new partners to secure the right partners is really key. And then lastly, I'll just share we found it really important to listen very closely to identify partner needs and underlying gaps, and then be able to respond with tailored support or solutions to advance progress. So this was significant with external partners, but also even internally in determining how we could be most helpful to colleagues and really bring added value to the work that we're trying to do. Next slide, please. So lessons learned are many, certainly, but two important ones are that this work can involve lots of patience and time, and diving into the minutia, as sometimes it's the details that can make or break the project. So for example, initially we weren't seeing an expected volume of referrals to asthma remediation services from the SCNs. And in the role that we play as technical assistance providers to the SCNs and HRSN partners, we uncovered back-end system issues within the SCN IT platforms that were essentially blocking the generation of referrals for eligible members. And addressing these details took a tremendous amount of time and prodding, but did result in fixes to support appropriate referral pathways statewide. So ended up being really important. The second is to remember that the road is long and sometimes feels super bumpy, but you can only overcome the roadblocks if you keep going. For me personally, this has required reaching out to Anne and Joel or Amanda on occasion for a pep talk on why we all just don't quit this difficult work, and to get a reminder on why we instead do it, which is to work towards ensuring that every child can live and grow in housing that is healthy for them and for their families. Thank you again, Anne.
Thank you so much, Lindley. That was great. And for those of you who have questions, please go ahead and share them in the chat. We can integrate them into the discussion next. But thank you, Lindley. We will now turn it over to Peggy Gaddy with the Missouri Department of Health and Senior Services.
Can everyone hear me?
We can, thank you.
Okay, good deal. You can go ahead and go to the next slide. And the next one. So in about 2017, we wrote a SPA in partnership with the Asthma and Allergy Foundation of St. Louis. They had a legislative champion, and we had to provide a lot of data to Medicaid. And their biggest concern is we were going to bankrupt them because of all the kids that had asthma. And we kept trying to tell them, you have to get in the home before you can charge for it. But they lowballed the reimbursement. It's $125. I think we'll get to a slide that says that, but it's $125 per visit with a limit of 2 visits a year. They also have a lot of caveats as to who can have the assessment, and it is the HEDIS, persistent asthma. They have to have the medication, they have to have been to the emergency room, those kinds of things before they even qualify to have the assessment. So we've not had a lot of success with that. And I know when I talk about we have 3 managed care organizations, I know California, I don't even know how many they have, but you have to become like a certified chronic disease provider in order to get reimbursed. And there's only one provider that can train in Missouri, and that's Southeast Missouri State, that can certify a person to be a provider. So that's another bottleneck. And so the managed care companies, it was required of them that they have to do the minimum. They have to do what we have in the SPA, but they can go above and beyond. So those are some things that we usually have to have conversations with them about. And the state of Missouri was adamant that we would not do remediation. We would not provide any bed casings, no vacuums with HEPA filters, none of that as an incentive for people to maybe invite you into their home and do a home environmental assessment. Next slide. So when the original SPA was written, it was written only for fee-for-service. That was the only children it was supposed to cover. Again, trying to keep the volume low. And then the next year, we went like 100% managed care across the state. Initially, managed care was just along the I-70 corridor between St. Louis and Kansas City. And then the whole state went managed care. So then you've got another whole group that you've got to bring on board and convince them that this is the right thing to do. And in Missouri, and I know in other states, managed care organizations get paid per member per month. So it's very difficult to calculate a return on investment because they pay the same every month, no matter if the child goes to the hospital or not. So who we really save money are the MCOs. It's not really showing a reflection in Medicaid. And so Medicaid, and I've already went over that we have one registrar. And one of the things when we were creating the SPA, the medical director of Medicaid was really involved. And she is a minutia person, and she wrote so many things into it. And she said it was one of the most difficult SPAs she had ever gotten past. So a lot of our angst with this SPA is attributable to her. So, we just didn't have a lot of control over what was written and what the reimbursement was. Like for self-management education, it had to be done in the home, and you get $100 a year. That's it. So there's not a lot of people lining up to get certified to do these services. Okay, next slide. So again, that tells you what the CPT code is, and $125 per visit, 2 visits allowed per year. And again, the managed care has to meet the criteria that Medicaid has set forth, but they provide they do provide bed casings. They can provide air purifiers. They can provide a lot of different things that straight Medicaid will not provide. But again, there's no real remediation. If we have a person that's in a sick home, it's left up to us to try to find them a better place to go. Next slide. So the 5 parts of our plan. Next slide. Build out the network of home environmental assessment providers. One of the things that we're doing currently is we're working with community paramedics in one county in the state. And they've already been through the training, and they have some agreements with the managed care organizations so that when they do a home visit, it may not necessarily be for an environmental assessment, but they get reimbursed for visiting patients that are frequent flyers. The thing about children is the community paramedics aren't going to have as good a relationship with the children and their parents as they will with older adults that have congestive heart failure, diabetes, all the chronic ailments. And those are the ones that save money because they're the ones that cost. So we have simplified the credentialing process as much as possible, but you still have to go through 4. You have to go through Medicaid and the 3 managed care companies. We do have asthmabridge.com, which is a centralized option for referral intake. About half of the referrals that happen to Southeast Missouri State go through the Asthma Bridge, and then another half are phone calls or emails. And we do have the managed care organizations like to use it. It's just that we're not getting a lot of reimbursement for it. Another thing that we're doing to build out the network, is we have faith-based community health workers. And the great thing about them is they don't care about reimbursement, and we're training them to be home environmental assessors. So that's another route that we're going, and not necessarily depending on reimbursement. And the other thing is you've got to have the Medicaid health plans to improve care coordination. Recently, I was in a meeting with one of our managed care organizations, and they said the best way to get in contact with their clients is email, and they have 11% of their enrollees that they have an email address on. And so we recently did a survey to find out Medicaid clients if they know who their Medicaid managed care organization is, and if they've received any of the added benefits like bed casings, air purifiers, and things like that. And we're finding out about 50% of the Medicaid enrollees know who their managed care plan is to even access some of these added benefits. So that's another hill you have to climb. And we have to have realistic expectations of family assessment of in-home services. We're the government and we're here to help. But I think a lot of times they think that they're going to be their children are going to be taken away from them. And one of the things that we really try to stress is poverty does not mean neglect. Poverty and the things that are going on in the homes in New York, previously discussed, those can be fixed. Neglect is another whole issue, but poverty sometimes is misconceived as neglect, and it's not. It's just they need help in getting done what they need to do to take care of their families. Next slide. I think that's it. And so we do all try to work together, and we try to accomplish what we can with what we have and try to navigate the systems as best we can.
Thank you so much, Peggy. Really appreciate that. So those were the two examples of state Medicaid policy changes that we're highlighting today. We are now going to shift a bit and hear from Natalie Tellis about a local effort to work towards sustainable financing for asthma home visiting. So turning it over to you, Natalie.
Thank you. Hi, everyone. I'm really excited to be here and talk to you all about what we are doing. Just a quick note, in the city of Alexandria, we are in Northern Virginia, right outside of DC, population of about 160,000 in 16 square miles. So we are small but mighty in Alexandria, and I'm excited to tell you a little bit more of our partnership work to make this happen. So next slide, please. I'm going to try to cover about 6 years of information in 60 seconds. We'll see how I do. So we started this work in 2020 when we were finishing our community health improvement plan. That is a 5-year plan that we do regularly as a local health department. And one of the strategies in that plan directly from our residents was to have a coordinated healthy homes initiative. So residents themselves said, this is important to us. Yes, we need way more affordable housing, but we need to start really having that conversation about housing quality and safety and how it impacts health. So that's the only reason that we're actually in the healthy homes business. So how we approached it is we built a coalition. We now have a Healthy Homes network of more than 35 different organizations that includes many different city agencies, that is nonprofit service providers, that is several property managers, all coming together to try to address this issue. We also have a home visiting program called ALX Breathes that actually serves both people who have asthma or COPD to do all the various home assessments and health assessments, education. We provide supplies. It's really important to highlight that I have in parentheses that multiple times bit about the program, because the program that we piloted way back when, years ago, is not what the current program looks like. And so one of the things that was really important to us is not to be wedded to one specific way of doing things, but starting with the evidence, working with our friends at NCHH and RAMP to try to come up with this concept of how we wanted to do home-based asthma work, but then also taking a lot of cues and feedback from our residents and redesigning the program based on their feedback. Also based on feedback was the creation of 2 Healthy Homes action plans. We are now in the second version of our Healthy Homes action plan that just launched in April of last year. I can't believe what time even is anymore, what that looks like. And so part of that plan is really looking at those big picture system issues that really are why we need a home-based program. So those city issues of mold, pests, hoarding, smoke, and other issues that can really trigger those asthma and COPD flare-ups. So we have things happening kind of at the same time, this parallel effort of this really big picture work to address our systems, our local policies, our setup around home conditions, and then at the same time, working through that individualized direct service aspect of our home-based program. So next slide. And so I will tell you a little bit about what has worked and some lessons learned. So next slide, please. Okay, one of the big successes from our work is how we started this work. When we were building our network, that Healthy Homes network that I mentioned, our coalition, we actually started with a workshop around human-centered design. So we wanted to get everybody on the same page first about what are our values? How are we going to approach these really, really big, tough issues about mold and pests and smoke? Those are not easy issues. And so we wanted to ground ourselves in what is the approach that we're going to take. And this is really important because we talked a lot about who is our audience with this work. And traditionally, I think a lot of folks just think, oh, it's just our residents, right? We're serving our residents. We're focused on giving them this service and all of that. But actually, we have multiple audiences. One are the city staff that are carrying out this work. Are they equipped with the training, the resources, the data, the tools, the ability to interpret data and make decisions? Are our policymakers knowledgeable about this topic? Are they equipped with the language to use and the anecdotes to use to help champion these stories? How about our property managers? How are we engaging those housing providers so that they are not just seen as the enemy, but a true partner in this work? Because something that we typically find is that shame does not really work as a strategy in general. It works in some places, but when we're trying to tackle these big systemic issues, we need them at the table. And so they are an audience as in a partner with this work. So getting us all on the same page of, okay, we care about this topic. We want to achieve policy change. We want data, good systems, people who are engaged, and programs that actually work. Not just a program just to have it, but really making sure that they are accountable. We are measuring their impact and being willing to change if it's not working the way that we want it to work. And then next slide, please. So I kind of mentioned this a little bit before, but something that was really, really valuable for us is kind of these parallel tracks where we are simultaneously addressing the individual need, the one-on-one home needs, as well as looking at the bigger picture structure. Yes, that took a lot more effort and time and work to do that. And it kind of split our attention a little bit because we don't have unlimited time and effort as a local health department team no one's job on my team is exclusively healthy homes. I should say that. No one has a title with healthy homes in the name or has that exclusive role. We all just fit it in bits and pieces. And so we have one of our amazing community health workers, Maria, in this picture on Telemundo promoting our ALX Breathes program in Spanish. So sharing about how we do pest management and education. So that's one approach for that direct individual. But then on the other side of the slide, you can see how we're using data to look at rodents and our systems. This is actually a heat map of Alexandria of calls that our city got about rodent complaints. So this is data directly from residents, and it ties also to our code administration office's data related to their system of violations and tracking. So ideally, in a perfect world, the stuff that we do on that right about hotspots and refining systems would make the stuff on the other side that Maria's doing not needed, right? I kind of have told our community health workers, my job is to put them out of a job, because if we fix the system issues, maybe we wouldn't need such advanced programming to tackle things on a one-by-one basis. Next slide. And then the third really, really big thing that we did to try to have success is centering resident voice. So I talked a little bit before about audience and what that means. We collected a lot of data throughout this process, throughout the last few years, to look at things about what's going on condition-wise, but none of this would really work if we weren't talking directly to the people who are most impacted and getting their perspective. Because if you use public health jargon with residents, it's not going to go over super well. Like, you have to use the language that resonates with people and that makes sense. Right? Do people really want to talk about advanced filtration systems, or do they want a safe place for their baby? Right? So getting to that space where you're hearing what they're saying and actually turning it into action is also how you build trust and relationships and bring things to fruition. So that image that you see here is an activity that we did from the world of human-centered design. It's a journey map. We did this activity with a group of older adults, and we were trying to talk about hoarding, in a way that was not scary or judgmental, but we made up a fake guy named George and we talked about how would George handle this situation. And the results from these workshops, we did a lot of them on different topics, are actually the strategies that are in our current Healthy Homes Action Plan. So not just community engagement for the fun of community engagement, but literally taking what people said, refining it, and now we're acting on it. All right, so then moving on. All right, so the big lesson takeaway / what could go right or wrong. Next slide. So as a local health department, we really don't have a lot of power. We have a lot less power than people think we do, right? We get a lot of calls from residents saying, hey, health department, like I need you to do this health inspection in my home and write a letter to my landlord saying they need to fix this, they need to address this. We don't have that ability. We don't have any regulatory authority to force landlords to do that or do any sort of inspection related to that, unless, of course, they're like a restaurant or a pool, right? Then we have some power in that way. And so a lot of the stuff that we could actually control was, one, our program that we do with people to serve them. But the rest of the work, all those other things that I talked about, the network, the systems change, the policy change, we don't have any real power. What we have is like soft power, right? We have relationships. We have the building blocks. We can lend our data analysis skills and convene people and talk about, okay, how do we think about strategy and approaching this issue differently? And that's really like one of the big takeaways. And I know we'll get to it in the discussion as well, but some of this really comes down to building those relationships. And sometimes that's slower than you want it to be, which can be frustrating. But for example, sometimes that means that you have meetings before the meetings, right? Individual one-on-one calls where I could call somebody from another city agency and say, hey, I'm about to do this presentation about your data. Can I show it to you first so you're comfortable with how I'm going to share this data? Or, hey, other partner or agency, we're thinking about this policy solution for this. What do you think about that? Before we share it, to not have any surprises, to build support before we do things publicly and get everyone on the same page. And that's really how we've gotten things done, by not forcing anybody because we don't have the ability to, but really to try to build consensus and relationships. And that's it. Looking forward to the discussion. Thank you.
Thank you so much, Natalie. Really appreciate that. Next, we're going to turn to our two final panelists are representing states where they started with some local work to feed up to broader work and think about different ways to scale and expand through innovative policy and practice approaches. So turning it over to you, Molly. Thank you.
Thanks, Anne. I'm Molly Zemke. I'm the program manager for Wisconsin's asthma home visiting program called the Asthma Safe Homes Program, and I'm with the Wisconsin Department of Health Services. Next slide, Joel. And I'll share a little bit about our journey. As Anne alluded to, we've had a asthma home visiting program in our state for several years, but I'm really going to highlight the expansion of our program just a few years ago through Health Services Initiative through the Children's Health Insurance Program. So just for folks who may not be familiar with Health Services Initiatives, and I am by no means an expert, but just a little bit of background for you. They're an option for state Medicaid programs, been around since the 1990s, that have a lot of flexibility to determine focus, scope, and design for innovative programs that can improve children's health. Since this is through the Children's Health Insurance Program, it's primarily focused on children as well as pregnant parents. It requires, so it's a combination of CHIP funding as well as state funding. So there is a state match. So obviously needing to get buy-in and approval of your state Medicaid office. But it can allocate up to 10% of total CHIP spending. That being said, there are often, for in our state in Wisconsin and likely other states that utilize health services initiatives, there can be multiple health services initiatives. So we are not the only one. We don't utilize, all of that administrative funding that can be dedicated to health services initiative. So we have a proportion of that, but it is a great option for states. You do have to submit a state plan amendment. I know a lot of talk about spas, so we did have to submit a state plan amendment or a spa describing the population we were going to serve, how it's going to make improvements to children's health, and a budget of what it's going to cost to implement this program. Next slide. So with that, I'll kind of share how we worked with our state Medicaid office to get this asthma-specific health services initiative. But this work really predates that back to 2014, and I'm sure the work even happened, much prior to that, to really get that initial program established. But back in 2014, our initial asthma home visiting program, called the Asthma Care Program, was developed with our CDC cooperative agreement. And when there was really a kind of some momentum and focus around home-based asthma services. So there was a small program with several local partners in Wisconsin to implement a program primarily focused on asthma self-management education in a home setting. And so that program was developed in 2014 and operated for several years. And we wasn't until 2019 that there was some movement around health services, some additional health services initiatives in Wisconsin. And one of those was actually to provide lead hazard abatement. So colleagues with us in the Division of Public Health within our Bureau of Environmental and Occupational Health here were able to secure a health services initiative to focus on homes of children and pregnant individuals with elevated blood levels, and receive funding to remediate those homes. And so that happened in 2019, and they operated that program for a couple of years. And in 2021, they needed to actually open up the state plan amendment, make some changes to their existing plan. And we, as colleagues, were in conversation with them. This predates my time at the department, but the asthma team here in Wisconsin, had been having conversations with them about the program and said, this would be a potential opportunity to talk with the state Medicaid office to utilize some of those funds to provide asthma home visiting services. So very quickly put together, pulled information from the existing pilot program, data about the need for this type of work, evidence from programs all across the country to demonstrate the need and effectiveness of this type of program. And so submitted that state plan amendment in 2021. Within a couple of months, had that approved in the state to be able to provide these asthma services as part of the health services initiative. And how that kind of works operationally is that we have a memorandum of understanding with our Division of Medicaid Services here in Wisconsin, and those funds are allocated to our team within the Division of Public Health. And we then worked over that first year after that was approved to develop requests for applications for local partners to apply to provide the services through the Asthma Safe Homes program. And so that launched in August of 2022. Next slide. So what we were able to secure with the Health Services Initiative is about $2.5 million annually. And that provides asthma education home visits. So between 2 and 6 home visits with a asthma educator. Those can be respiratory therapists, community health workers, nurses, public health nurses. We have a variety of professionals that provide those as home visits to provide asthma self-management education as well as a basic home walkthrough. serving up to about 400, the ability annually to serve up to about 400 clients. All of those clients also receive what we call durables or home supplies or remediation supplies, as folks have referred to them, to address some home asthma triggers. So things like vacuums with HEPA filters, asthma-friendly cleaning kits, air cleaners, dehumidifiers, and those that can be up to $1,000 per client that is provided for all clients that participate in the program. And then a subset of clients, about 25 to 30%, can be referred to within our program to receive a more comprehensive home assessment, as well as potential remediation services to address sources of asthma triggers up to about $5,000. So things like you've heard in terms of addressing mold or moisture issues, removing carpeting, improving ventilation in the home, pest service, pest control. And so we work with local healthy housing providers, home repair providers, contractors in our target service area to provide those services. And then also included in that $2.5 million annually is training. So we're really lucky to have built in training opportunities for the providers that apply to be part of the program. So we've worked with, contracted with training providers for both asthma self-management education to prepare asthma educators for this program, as well as on the home assessment and repair side to prepare our contractors and assessors. And then there's program administration costs. My position, there's a grant specialist as part of our team as well. We have a program database, so the kind of administrative things as well. It supports through the program. Next slide. So some factors that contributed to our success in securing this health services initiative. You've heard some of these things already from others and from Anne's kind of opening remarks. Definitely for us, it was participating in relevant reimbursement technical assistance opportunities. And we still participate in technical assistance opportunities to sustain our current work and in the hopes of even expanding our work beyond kind of the health services initiative. But in those early days, I know for the team, that was really important. They participated in, many opportunities to kind of understand the different funding mechanisms, the different approaches, and things that would be helpful to prepare when the opportunity would arise to potentially secure more sustainable funding. That pilot program that I talked about through the CDC cooperative agreement, that was really critical. A lot of feedback from our, state Medicaid office or from other stakeholders about really wanting to see the local successes of, the effectiveness of asthma home visiting, though we can obviously point to, really documented evidence across the country around this type of work. It was really helpful to be able to say, we have residents in Wisconsin that have participated in this program, and these are the outcomes they experience, the positive outcomes. And so that pilot program was really critical, as well as definitely setting us up for success when we got the health services initiative to be able to really hit the ground running and implement our program more broadly. And then, as I just mentioned, right, really collecting and sharing those performance metrics around, our program outcomes with the pilot program. And we continue to do that, obviously, through our current program, but that was really important as well. Next slide. And so our big lessons learned, and there's more we can discuss through the Q&A, but really, knowing it was really helpful and really important to know your, the pitch and the selling points. And that had a lot to do again with, that we documented the need for this type of program. We documented the kind of success with the pilot program, the outcomes, and that we were ready and able to implement this program. So just having your kind of selling points around a potential program, really leveraging that. I kind of already mentioned this, but being ready when the opportunity presents itself. I know I heard from my colleagues who were part of, writing the SPA and really mobilizing when there was that opportunity when our lead colleagues were, had the opportunity to kind of open up the state plan amendment, and we had this moment in time to add these asthma home-based services. They had to be ready, and they were ready. And that is, I think, a really important lesson learned is you don't know exactly, spend so much time preparing and in trying to strategically plan for, having, sustainable funding kind of opportunities, and you don't exactly know when that opportunity is going to arise. And so, having what you kind of having things available to you to be ready to jump in. And then, time and investment is needed to establish the program. I think that is, obviously we've heard that from so many folks today that, you know, really thinking about, I know that our pilot program in Wisconsin, that was, 2014. So just thinking about, how much time we needed to invest in this work and, continue to grow, through over a decade, right, of work. And so really taking the time to establish the program, learn from others. So much of this was learning from other programs across the country, that technical assistance, and just really making sure that you devote the time to establish your program. I think that's it for me.
Thank you so much, Molly. Really appreciate hearing your story. And now we'll turn to, last but certainly not least, Paula Hooligan with New Hampshire.
Great. Thank you very much, Ann. I'm very happy to be here today and appreciative of the offer to present on the program that we're working on in the state of New Hampshire. So I'm going to talk with you about mobile integrated healthcare. I know others have talked about community paramedicine, which is another term for that. So we use mobile integrated healthcare, and I'll explain a little bit about this in the next couple of slides. It's also affectionately known as MIH. And this is what we use for New Hampshire home-based asthma services, and I'll talk a little bit about that in the next couple of slides as well. So next slide, please. So why MIH? We have gaps, just like many other states. Across New Hampshire, we see high-need patients who face real barriers in accessing care, things like transportation challenges, medication confusion, not knowing how to use medication, or maybe some unsafe home environments, such as mold, for example. For many of these individuals, the emergency department becomes the default entry point into the healthcare system. We also have what we call super users. So those are people who repeatedly rely on 911 or the emergency department because their primary care, social or behavioral needs aren't being met in a traditional healthcare setting. And in our rural communities, and most of New Hampshire is a rural community, the distance and fragmented services make these gaps even wider. So this is where MIH steps in to address those gaps directly. And next slide, please. So this is a definition, one of many, of what mobile integrated healthcare is. So as I mentioned, it can help fill the gap in traditional healthcare. It's a team-based approach that uses EMS providers of any level. That could be an EMS, EMT, a paramedic, or an advanced EMT, and also other people within healthcare, even social needs environments, such as nurses, social workers, and even CHWs. So what they do is they meet people where they are in their chosen environment. And MIH team's work focuses on prevention, early intervention, and tight coordination with primary care, hospitals, public health, and social services. MIH can also conduct asthma home visits to identify and help mitigate asthma triggers, provide education, and make connections to services that people living with asthma may or may not have, reference or know where to go to get those services. So MIH isn't designed for emergencies. It's designed to prevent emergencies by stabilizing patients, resolving barriers, and improving disease management. The overall goal is to have fewer ED visits, better chronic disease outcomes, and more support for patients where they live. So as I mentioned, these visits that they do as MIH providers, whether it's an individual taking a clinical side or a CHW addressing social needs, they're working together for our asthma home-based services within the state of New Hampshire. And next slide, please. So what does MIH look like in practice? So these are just a couple of examples here of what MIH providers can do, and it really depends on the state. These are what you would see in the state of New Hampshire for their EMS protocols. So it basically provides essential in-home clinical support, as you can see, medication reconciliation, making sure people are using their inhalers correctly. As we know, people, about 80 to 90% of people don't know how to use their inhaler correctly, have never been shown in some cases. And also, are they using their medication consistently? And they can also help for lower cost medications, finding those avenues as well. So as part of our asthma home visiting, MIH providers can also check inhaler technique. They'll do the home assessments. What we do is we use the EPA's asthma home environment checklist, where they'll identify what those asthma triggers are, and they will make connections. We had one MIH program, had a couple of things. The person only spoke Spanish. We were able to bring in an MIH provider that was able to speak Spanish, was bilingual, in fact, and we were able to work with that individual. They had mold in the house to provide some mediation with that. So while in the home, what providers do is they monitor and record vital signs regularly. They provide wound care management. They'll do fall assessments, home safety assessments, including CO detectors or carbon monoxide detectors, and also smoke detectors, making sure those are available and installed correctly. They'll also support patients that are managing chronic conditions such as asthma, COPD, diabetes, and hypertension. And they'll do this all through ongoing monitoring, education, and care coordination. So following hospital discharge, what MIH providers do also is they conduct follow-up visits and check-ins to reinforce the care plans that the person got at their discharge. They'll address complications early, and they'll help to improve the recovery outcomes because they're there and, again, preventing a wound from getting reinfected, as an example. They also help coordinate telehealth appointments with a primary care provider or other specialist, and then connect patients with needed social services and community resources to support overall health and stability. And then lastly, they address social isolation by providing regular interaction with patients, wellness check-ins, and support to keep the patients engaged and connected. MIH visits include asthma home visiting. We also work with the caregivers within the home as well, if there are caregivers, to ensure that they understand what the patient's care plans are, how to use their medications appropriately, what their asthma action plan looks like, and what those triggers might be so they can be on the lookout for those. And I believe there's another part here, Joel. Just press the space bar. I wanted to point this out. This was a Facebook post from one of our MIH providers that lives in the most northern part of New Hampshire, which is extremely rural. And as you could see here, this is just another example of what they're doing beyond just the clinical care, but serving these very important social needs, such as filling a sled of firewood for someone that's homebound. A person was not able to walk. They also frequently take trash away so that people don't have pest and other rodent problems as well. So addressing truly, as he says here, all health concerns. And next slide, please. So MIH funding in New Hampshire, there's a lot of different models here that we use in New Hampshire. So for example, we have the CDC funding through the New Hampshire Asthma Control Program, and there's also HRSA funding through what they call a Northern Borders Grant. So these grants help to launch and sustain innovative community-based healthcare initiatives. Some of the other MIH programs are financed through community benefit funding. So nonprofit hospitals are required to invest in programs and services that improve community health to maintain their tax-exempt status. So what community health benefit expenditures, what they may include charity care, coverage for Medicaid shortfalls, and other investments that address social determinants of health, such as housing stability, food insecurity, transportation is a big one for New Hampshire, and also access to care. Some of our MIH programs use what they call a blended partnership model, and that's combining support from local government and public safety budgets with healthcare system investment through, again, community benefit dollars and also population health funding. So this collaborative approach helps distribute the costs while aligning healthcare, EMS, and community service goals. At this time, we only have one NIH program in New Hampshire that is actively billing Medicaid for services. We are working on that right now. What we are doing is we're working internally with our state Medicaid personnel to establish some codes for Medicaid for reimbursement for different types of services. We're also seeing some emerging opportunities like the community health integration codes that are being used successfully in certain regions nationally. Long-term sustainability will depend on strong outcome data and payer engagement, which we're also doing as well. And next slide. So key factors for success, I think a lot of people said this before, is the strong cross-sector partnership. And it's basically NIH specifically works because of relationships. The strong partnerships across EMS, hospitals, primary care, Medicaid, and community organizations make it possible to coordinate care effectively. NIH clinicians, they provide a very unique advantage. They're in a patient's home. They see things that primary care hospitals and others may not because they're in the home. They could see that, oh, the person is out of medication, but they're too embarrassed to tell their primary care provider. But EMS is a trusted source, just like CHWs, and the person is opening up to that individual and talking about things that may or may not make it to another healthcare provider. They can also find expired medications and help to address that as well. Empty refrigerators and also some of the transportation barriers, they can help make connections for those. So the insight builds trust and it creates opportunities to intervene early to prevent problems such as asthma exacerbations. Another really important thing is data, obviously. Very critical success factor. Standardized assessment tools, very important, and consistent reporting help to demonstrate impact, especially as we engage payers. And early experience shows real outcomes such as reduced ED visits, safer transitions of care, and better chronic disease control. Ultimately, NIH keeps people healthier, safer, and more independent while reducing the strain on the healthcare system. We're seeing some early demonstration of cost savings, particularly reduced ER use for asthma patients and those with other chronic diseases. One of the biggest challenges I wanted to mention is that what we're seeing is with many EMS providers, they don't know where to begin. You know, they know responding to an emergency, but what about post-emergency when you have more time? And what are those social organizations that they may or may not know within their community? So how do we make connections with that? So they know that NIH is valuable. They see the patients who need this kind of support, but they often say they feel like they're building the plane while also flying it at the same time. And the truth is that NIH is really complex. It blends clinical care, social support, community partnerships, and systems navigation all into one package. No one should have to really figure that out alone. So what we've done is we've actually worked, we meaning the Department of Health and Human Services, our division specifically, we're working with EMS to create a toolkit and online for everybody, bringing together a community of practice so that people can share their story, share their information, even have a template like building a job description for an NIH provider. They don't have to do that from scratch. So sharing information is definitely essential. Every NIH program in our state has learned something, what works, what doesn't, what payers want to see, what leadership at hospitals want to see, and how to navigate the realities of home-based care. When providers share these lessons, it shortens the learning curve for everyone else. Instead of starting at zero, new programs can start about 50, maybe 60% and build from there. We've started an NIH community of practice, as I mentioned. What we've found is that there's no one size fits all in the state. What works on the western part of the state is not going to work in the northern part of the state. So we take those into account as well. And what we do is we help to find solutions and maybe some modifications as well. And next slide. So some of the lessons learned here, as you can see, is engaging your stakeholders early and be persistent. And what I want to say about this is that your stakeholders early, you can't just show up when your program is running, because they provide vital input for how that program is going to work. They should also be persistent in meeting. If you're working with a hospital, which we found to be uh, very successful, is working within a hospital system, meeting every department there and being persistent about meeting with them. Show up with donuts and coffee, give a training, follow up once a year, find out how the referrals are going and how the services are going, what improvements can be made. It's also important too to learn to connect with other MIH programs. What we found in New Hampshire is that all the MIH programs in the state are working in a silo. So it's really important to have all those resources together that can share and not have those same stumbling blocks that many of the other programs have had. And then also starting with pilot successes. One of our programs is actually working with an outside consultant. And what they're doing is they're looking at their successes, and they've only been around for 1 year and are very successful already and have reduced their ER visits by 40% in that time period. So starting small, and what they're doing is they're hopefully going to expand to a much larger area in central New Hampshire on that. And next slide. And that's it. This is my contact information, and this is a QR code to our website. If anybody has any questions, looking forward to the discussion. Thank you.
Thank you so much, Paula. And we will share the slides with everyone who registered, so don't worry about needing to scan that right now. So we're now going to move into some questions for all of the panelists. And one I want to start with is on the topic of partnerships. I think every one of you mentioned the importance of partnerships in this work, and I think it's a sort of core value to all of us who are working in public health. But I heard a lot of an array of partnerships, from our community members to state Medicaid directors to MIH to other programs within your health department. I'd like to invite any of you to take a moment to reflect on key lessons or specific guidance that you would provide to others on this webinar based on your work in developing partnerships toward this end goal of sustainable financing for asthma home visiting. So who would like to start? Natalie, I see you unmuted.
I can jump
Great.
in. So yes, we do have a lot of partners. A lot of them are in our Healthy Homes network, so in that coalition. So the way that we try to approach our partnership work is by being very mindful of what are their goals. Like, what do they care about? What is the scope of their responsibilities, so that we are not trying to ask everyone to do everything, right? So for example, we might have our friends at the Office of Housing and the Office of Code Administration locally. We do a lot more work with them on like the nitty-gritty bits. So that might be doing wording for scripts over the phone, or that might be process flows or very specific pieces like that of like the technical aspects. And that's how we work together on a monthly basis. Other groups, we have partnerships with advocacy nonprofits, so people who are speaking out for tenant rights. For them, the relationship might be more about, hey, can we have 10 minutes on your upcoming community meeting so we can present a draft of our new mold website and get feedback on that? So being really mindful of like, what is the role of each different relationship, so that you're also not burning out all of your partners, and finding the right fit for what are their strengths, what are they bringing to the table, and how does it align with their mission, so they're also achieving their goals as well as your collective goals.
And I wanted to jump in as well. I appreciate that, Natalie. I think I 100% agree with everything you said on that. And I think in regard to the roles, if I look at MIH in New Hampshire, from a state standpoint, we're doing the same thing, working with the housing authority. We're working with schools and different things like that. We get calls from our MIH providers. I've got this person that has XYZ. What do I do? Well, I'll make a referral, but that's because we're doing that legwork too. And it's amazing, the web, we have actually a group that we meet monthly. And it's all the different parts of DHHS. We're all learning what each other does. So we have all these contacts that we're building, and we can relay those out to the MIH team. But it's also the partnerships within the MIH teams themselves. Not only is it the leadership at a hospital that has to have buy-in, but you have to get buy-in from everybody. You've got to get the CHWs. And a lot of things, like I mentioned in the presentation, have been siloed. The CHWs are working in silo, MIH is in silo. So bringing everybody together, because many hands make light work, and everybody is under-resourced, and coming together to do all this work is really important. But definitely identifying those roles and what their missions are is extremely important.
Thank you.
I could share a little bit from Wisconsin, just really kind of piggybacking on what Paula said, really, thinking about kind of, and Natalie, like whose work is kind of aligned with yours. And I know for us, in terms of, securing that initial funding, our lead abatement program here in the Division of Public Health was a critical partner, obviously, for us to be able to kind of join in on the Health Services Initiative to secure the funding. But they also were, and they continue to be, really great partners in helping us connect with, local organizations or contractors who already do, lead abatement work and maybe healthy homes work, and can be a partner with us to do asthma remediation, because that's not something that a lot of contractors are just generally like, this is something I do, a service I provide, but it does align really well with other types of work that exists. And so, that was a really important partnership that we had. And then just really leveraging the partnerships that we had through our pilot program. We continue to work with some of the same organizations, healthcare and other community-based organizations that initially implemented our pilot program. And they were even great at connecting us with other organizations that might be well positioned to implement the program, that they, help make connections and helped with networking. So I think just really finding those champions in this work, and that can obviously, be really important partners to sustain the work, and then even to kind of grow beyond that.
Thanks. Lily, I know you touched a lot on the topic of partnerships through your initial remarks. Are there any particular reflections you would like to share?
I think it's just been interesting as the work has expanded under the waiver to be inclusive of the actual remediation components of the work. And that's been, I think, an adjustment, an area of growth for us to branch into identifying those home improvement contractors who are providing these services, and, kind of recruiting them to the table, which is difficult. I would say it's one of our biggest challenges, and it, as Molly was saying, has been really helpful to connect with the New York City Healthy Homes program, for example, at the New York City Department of Health and Mental Hygiene, because they do have more of a working relationship with some of those providers, but also just to explore new avenues of partnership. For example, we're attending a conference upcoming at the end of the month that is with the Building Performance Association, which, isn't something we probably would have been involved at prior. And so now that we've expanded into this realm, it's finding who those partners are and where those partners convene, really, and just trying to get the word out.
Great. Thank you all. So a common theme when we talk with groups across the country is that there are multiple pathways for doing this work. And in many cases, a single state or community will pursue multiple pathways or be on one pathway and then take a turn. And I wanted to invite any of you to reflect on the pathway that you're on now. Either why did you choose that? How did you get there? Or what have you found as the particular value of that pathway? Whether that is a particular state policy mechanism, or whether that's a decision to work locally, balancing the individual and community approach. Lily, if you want to start, that would be
I'll just
great.
jump in quickly. So I think that I wouldn't say we had too much of a choice in terms of, needing to redirect to the social care model, but in hindsight, see the benefit of that as being um, inclusion of asthma remediation services makes it a requirement for all of the social care networks to be implementing and providing these benefits to eligible Medicaid members. Whereas had we been or continued the ILS approach and pursued the in lieu of services, that would have required voluntary participation from the managed care organizations to opt to, provide these services. So I think that, of course, there's pros and cons to every policy approach, probably, but I I think for us, like I try to be or want to be prepared to adjust paths, like you said, and be pursuing maybe multiple policy pathways because you kind of never know how things will play out and what you'll need in place in the future. So one thing I'm interested in learning more about the health services initiative and better understanding where New York State is, in that. So I think there's just always so much to learn from this group and what other states are doing.
I can
Great,
share
thank you.
just as I mentioned in my presentation, the opportunity really arose for us to for the health services initiative, and so that was just the right opportunity at the right time. I think reflecting on that, I think the a really important benefit of that to our state is we're implementing the program really within the Division of Public Health, so we have a lot of flexibility about how the program is delivered. We also had the benefit of learning from lessons learned from other states who wrote state plan amendments. We tried to keep it as broad as possible to not kind of box us in with, who can provide the services, what's provided. It's pretty left pretty open. And so we have a lot of flexibility, at least at the time, at this moment, within our program to, make decisions and make changes to our program. We're constantly making improvements to our program. So that's, I think, a real benefit of the Health Services Initiative, at least the way that we ultimately implement it here. It may look different in other states. I think a drawback, and we were, thrilled to have this 2.5 million, year after year. That is, greatly expanded the scope of our program and the reach of our program. And it stays the same. So, as we grow, we're going to get to a point where we can't, see more families, we can't remediate more homes. And so we are exploring other options, if there's a ability for providers to directly bill Medicaid, that would just greatly expand our ability to this Wisconsin's ability to serve families. So definitely pros and cons of the approach that we selected, but definitely have had a lot of success because of, I think, the flexibility it's provided us to establish this program and then hopefully grow it in the future.
Smalley. And Natalie, I know it really struck me in your presentation, the balance between the community approach that really does get at primary prevention, in addition to the direct service approach to get services that are really needed to people who are experiencing asthma exacerbations. And I wondered if you just could reflect on that as an approach and any lessons you'd have.
Yeah, so it's funny. So so I mentioned in my timeline that we really started a lot of this work during COVID, which is crazy for a health department to start anything new during our COVID response. But we were jumping on an opportunity, a grant that came around. So we just took advantage of this opportunity where really it was less focused about the asthma piece and it was more about all those environmental conditions because people are spending a lot of time at home. And are we making them actually sicker by spending so much time at home and those sorts of challenges? I think taking that community sort of systems approach rather than solely just focusing on the one-on-one direct service really helped us build buy-in. Because, for example, our members of council aren't necessarily getting emails about asthma. They're getting emails about mold. They're getting emails about rats. They're getting emails about our public housing agency. So really by being able to address some of those topics without it necessarily having to be just about the health condition really helped us to bring awareness and buy-in to all of those issues, which then led people to talk more about the asthma eventually when they saw how it all fit together. But when we tried at the beginning, especially to try to find money and resources to have these conversations, they didn't go really well at first, honestly. Like we were ghosted by our state's Medicaid office. So that was not a great experience. So we tried right at the beginning to go for the money, and we weren't successful because I think we hadn't changed the culture of the conversation. And that's what we spent a lot of time doing, is really changing the dialogue from just affordable housing to safe and affordable housing, quality affordable housing, and really changing the narrative. And I think being able to do that has made it more of a normalized thing to say, yeah, we should invest in that. Like, yes, this is a thing that's really important to our community. And we still have the data that talks about the asthma hospitalizations as an endpoint to measure success. Like that's still in our minds, that this is the endpoint of we're reducing these hospitalizations. People are better able to manage their chronic conditions, but we've built a big tent to help us get to that goal.
Right. And Paula, in your choice to focus on mobile integrated health, we have a question from the audience that is relevant, which is, what is your sense of how common these types of efforts are in other states, and how might someone go about building that connection with MIH to support sustainable asthma home visiting?
I think we're starting to see more MIH programs, and I know there are other states that are further along than us. Some of them already have worked with their state Medicaid office to get reimbursement codes for MIH. We're just starting that, and what we've had with MIH in our state for a number of years is grant funding, but everybody wants that sustainability piece. And I know one of the efforts here, we're seeing more people, especially as the Rural Health Transformation Grant comes out, that are very interested. Just yesterday, I got another call from somebody else interested in this, and how do we start? The nice thing is we're all at different stages, and local places are calling me to ask how they even get started with this. So just, I think making some national connections, I think is really important. Other states, like I said, are far ahead. Some haven't started and some are just thinking about it. And I think having an avenue where we can all share the information, because, we could take bits and pieces from other states to learn on that.
Great. Thank you all so much.
You're
One
welcome.
last question before we turn it over to Amanda for some reflections. As I think about the conversations today, your presentations, and our work with states across the country, I think three words really come to mind of partnerships, flexibility, and persistence really being key to this work. Do you have any words of wisdom or words of encouragement for people that are struggling on this pathway? Maybe it's they're facing setbacks. What would you say to people in that position now?
I'd like to start. And I don't remember who it was, and maybe it was Molly that had this slide that said, don't quit. But they said, do it. It was a really nice thing. I actually wrote that down. I really liked it. But I think that's the thing, is keep going is really important. Things will need to change, and you have to be flexible, because you may go in with a goal and a plan and find obstacles, challenges, or other things that you might have to veer in a different direction. I think it's really important to have champions as well for this, because, and for the example of MIH, EMS providers and primary care providers, even ER docs, don't even know what an EMS provider does. So that level of trust needs to be established. So if you get a cheerleader, such as a primary care doc, that could say, look, I can advocate for this, and I think it's really important, to have that. But I think you have to be willing to maybe change some things and encounter head on what those challenges might be, and understand that, even though you want to go through and they always tell you not to make changes, you might need to make some changes. Your evaluation, your data might show you need to do that to be successful.
Right. Thank you. Lindley?
Yeah, I think it's really
I know you
key.
were the one with the don't quit, the do it slide.
Right.
It's such a great message.
So other than, calling Joel and Anne and Amanda for the cheerleading sessions, I do think trying to surround yourself and identify those right partners who I described. And right partners could include partners that just feel strongly that this should be the norm for children with asthma who are experiencing ED visits and hospitalizations, right? So in New York State, we convene an asthma partnership of New York, and we just recently met, and it was just really inspiring to, I think, be surrounded by so many partners who have that shared passion in this work. And it feels like you have the momentum to kind of keep going because it can feel very slow and hard, and it's easy to feel like you want to give up, I think. But that's one thing that's really been crucial to me over the years is just, relying on partners and folks who are trying to do this work be my inspiration to kind of keep going.
I'll just hop in because that was going to be my sentiment exactly too. Really, just I think Anne, you said persistence, and that's I think really, the thing to consider that, you are building towards something. I think we're all evidence of that, and it might not look exactly like kind of what you expected it to look like, but know that there will undoubtedly come an opportunity where something can grow from all the work that you're putting into developing your programs and your work. And very much what Lindley was saying, just in terms of personal inspiration and also just really using that community, the folks that you have around you, the partners you have around you that are on the same page as you, obviously just help you keep going, but also can be really good advocates for the work too. I think we have not done this much recently, but we're really starting to use our program provider, not use our program providers, but encourage our program providers to tell their story. We actually had a storytelling workshop recently with them about how they can really talk about the impact of their work. And that will be an opportunity, obviously, just to share the good work back with the community, but also potentially, to share with potential funders or other partners that could expand the work and say, it's one thing to hear it from us at the state level and one thing to hear it from a respiratory therapist at a hospital, the children's hospital, who's going into people's homes. And so we're really going to be trying to leverage that more coming up as well.
Right.
I'll say very fast. Sometimes throughout the work, when things are getting hard, I sometimes have to redefine what success means. Where sometimes you see it very much as like either I have this program or I don't have this program. I got this funding or I don't got this funding. But instead, trying to really look at the process steps that we've made along the way and being able to celebrate those, right? Of like, oh, we got this new member of our coalition. Like we have a new network member. Like that is awesome. Or we heard one success story, just was shared. Like we have this one anecdote about a kid who can breathe better. Like just that will sustain you, right? Just finding those things that may not be like the big, huge milestones, but those things along the way that get you there can really sustain you to keep going.
Thank you all so much for sharing those reflections. Next, I'm going to turn it over to Amanda Reddy, Executive Director of National Center for Healthy Housing, to share some of the resources that are available for others who want to keep going, as well as some reflections on the day.
Well, thank you to our panel for those excellent and inspiring presentation. And I think, some of what I was reflecting on here as I was listening to all of you was just, that constant theme about the fact that this work has always been done, continues to be done in many different ways across many different contexts. We heard again and again that there isn't, that there are multiple pathways, that there's not just one model, both across places that you may have to, hear these stories, but adapt it for your local context. But even within a single place, that we may need to adapt and pivot across time. I think, Natalie, you were the one that said, don't be wedded to one way of doing things. And Lindley talking about what the last 20 years of evolution has looked like in New York State. I think it's also clear from all of these stories that this work takes a lot of time and a lot of care, not just to get across the finish line, but to sustain, right? And At the same time, I also heard this constant theme of readiness, right? That states and communities that have been successful have, are often able to describe a specific moment when an opportunity arose. And maybe that comes 2 months into your journey or 20 years into your journey. And Lindley, you again said, I think this happens over and over again. And so there's just this need to sort of stay ready. And I think one of the best ways that I've seen communities get ready and stay ready in an evolving landscape, nationally, locally, at the state level, is by staying in those relationships and conversations. Paula, I loved what you said about how MIH works because of relationships. This all works because of relationships. So staying in conversations with those interest holders in your states, but also with your peers across the country who are doing similar work, or as so many of you said, who have similar goals and similar values to you. And I think that this really, what I am really struck by in all of these conversations is how every time we come into a space like this, every single one of you, not just the panel, but every single one of you, even on this call, is here both as a learner and as a leader, right? We heard Lindley say, you were probably in the audience listening to her thinking about, oh my God, what an innovative, amazing model. But then she's sitting here taking notes saying, Molly, I want to hear more about that, HSI. And Paula saying, we've got something good going with MIH, but I'm learning from these other states who are doing it. So just want to really reinforce how powerful that learning mindset that all of you are bringing to the table really, really is. And one of the best ways I think that we can help support you stay in conversation with each other and stay connected to these stories, you can move to the next slide here, is by helping connect you to these stories and to more stories. Both NCHH and RAMP have been in partnership for many, many years to provide free, on-demand, responsive technical assistance to folks like you who are trying to advance this work. Our approach to TA is probably different than a lot of models that you've experienced. It's not meant to add to your workload, but really to help provide a support and to help you advance to your goals, really meeting you where you are instead of being a one-size-fits-all. You can see on screen some of the kinds of support that people will reach out to us for. And Molly, you said at one point, be ready with your pitch, right? That's something that a lot of groups sometimes, you want a thought partner to help you. We can help be a thought partner for you on that, right? There are many, many ways that we can help support your conversation and your work here. With just our last few minutes, I'll highlight quickly a few tools here. First, on the next slide, I'll mention our roadmap for sustainable asthma home visiting. RAMP and NCHH partnered to create this tool, recognizing that although there are sort of key components and steps along a pathway, they're often not linear and people do them in all kinds of different orders. There's really not one right way to get this done. Not only is there not one model, there's not one right way and one right path to get there. And so the nice thing about this tool is that you can move these 9 waypoints into different orders, drag them into the order that makes sense to your mind or to your local context, and generate a customizable roadmap for building this kind of work in your community. If we move down to the next tool, I'll highlight also another jointly developed resource is Unlocking the Power of Home-Based Asthma Services, which is a model health benefits package. This was targeted towards the managed care organizations and healthcare payers, but it's also a really valuable resource for really anybody doing this work and can really, again, underscore there's not this one size fits all and help support those conversations, not of are we going to do this or not, but what is our design of our program going to look like? What is the scope of the services? Just changing from should we, shouldn't we, to what is it that we're going to actually support and fund moving forward. And I just want to close out here by really emphasizing to all of you that support is available. We'll make sure all of you know how to get in contact with us. And that you are not alone. Sometimes we say we're in this together, but I hope you're leaving here understanding that you are in this together. All of these resources that we're showcasing here is because all of the work that you guys are doing, your generosity with sharing the lessons learned from the ground, both the big themes, some of the big themes, but as I think was said during the conversation, also sometimes that minutia too, the real specifics of like this is the specific code that got us past, this is the specific framing that helped us advance. And we look forward to staying in conversation with all of you as you move this work forward.
Thank you so much, Amanda. Great reflections. And I'll second her encouragement for all of you to reach out to us as you are hopefully leaving this webinar feeling more informed and fully inspired. I would like to invite everyone to take a brief survey to let us know how this went. So there will be a link in the chat. It's very quick and we will use the information. So thank you for your time with that. And I want to thank again all of our panelists. Really appreciate you sharing your experience, your expertise, your time, and your thoughtfulness to approaching this very important work together. So with that, we will close. I want to thank you all for joining us today and look forward to future work together.